screen and start to extend to the second panel. We've got a critical mass. So welcome everyone. It's great to see so many faces pop up on our virtual screens. We are welcoming you to the 2021 Pediatric Health Services Research Seminar hosted by the Susan B. Meister Child Health Evaluation and Research Center. Just by way of some introductions, I'm Kara Janis, a postdoctoral research fellow here in the center, and with my co-coordinator, Melinda Rushing, we are delighted to introduce our speaker today, Dr. Jade Burns. So a little bit of background here. Dr. Burns is one of our own experts here in the University of Michigan research ecosystem in pediatric and community-based health services research. She is currently an assistant professor at the University of Michigan School of Nursing, where she directs an active research agenda using community-engaged approaches and technology, such as social media, messaging, and digital spaces, all to increase access to sexual health services for adolescents and young adults. She holds a BSN from the University of Michigan, a Master's of Science in Nursing from the University of Pennsylvania, and a PhD in Nursing, again, from our own institution. We are thrilled to have Dr. Burns' expertise with us today, especially given that so many in our center have a shared interest in leveraging technology to improve pediatric and adolescent health. So with that, Dr. Burns, I'll turn it over to you. Melinda and I will be monitoring the chat. So should anyone have any comments or questions, you can throw them in there and we can address them at the end. Or if you prefer, Dr. Burns, you can take interjections however you'd like.
Okay, good morning. I don't know about the rest of you, but I'm juggling a bunch of stuff right now. Kids going to school, faculty seminar, there's a dog in this room, but we're gonna make it today. And I'm really, I'm very honored to be here. I will share my screen later, like, when I start the presentation, but I just wanted to thank the folks here at CHEAR. I'm honored to be here with you again virtually to discuss building community partnerships, the Young Men's Health Matters program. And I would like to thank a special shout out to Dr. Sarah Reeves, a faculty investigator at your center, and who referred me to speak. I believe she referred me to speak. And we both serve on the Institute for Health Policy and Innovation's Early Career Faculty Council. I also like to thank the staff at CHEAR who graciously put these events together and reached out to me. Thank you to my funders, the Detroit Urban Research Center, the Institute for Research on Women and Gender, the Ginsberg Center, the University of Michigan School of Nursing, and of course my community partners, Detroit Community Health Connection, who has 7 health centers all over Detroit. They are a nonprofit community-based primary care organization committed to providing accessible, affordable, and quality services to all members of the community that we serve. And if it's okay with you, when I do my presentation, it's okay if I turn my camera off at some point. I don't know if that is going to bother somebody.
Absolutely, please.
I just want to ask real quick with the folks who are on here, who are on the call, if you can drop in the chat if you'd like. But how many of you work with community partners? Do any of you work with community partners, or is it, I know I see hands raised. I know that it could be a lot of inpatient or sometimes payment models, but do you actually go talk to the community? Okay, good. Someone said Detroit Urban Research Center, yay. Okay, good. So it's really important. So when you see my presentation, I have your logo on there as well as the University of Michigan School of Nursing's logo, which is We Dare. And that's our brand. So at the end of this presentation, I would like for you to think, like, what do you dare to do as health service researchers in your research? How do you put the community in that picture? And so that's an important thing to consider. And I'm looking at the chat right here. I'm a part of a community action against asthma. I'm part of I don't know if I'm supposed to be looking at the chat and doing this at the same time. But patients and caregivers, patient advocacy groups, so good. You all have some experience in terms of community. And as a nurse, community is a huge part of what I do. And I've worked there for a very long time. So I shall get started. So, and we shall get some CMEs in here and CEUs, right? So let me share my screen. Okay, so that's me. And I have a couple of my social media handles on here, which is Twitter, and at my own lab, I have a lab with students called the DRB lab. And so who am I? I got a great introduction today, but I just wanted to let you know that I am a researcher, a clinician, a consultant, a community and pediatric expert. I am a mother. I have one son. So today is National Sons Day. So I wanted to give another special shout out to my son, Robert, or we call him Bobby. I'm a wife and I love social media, pop culture, sports, running, traveling, and spending time outside. And here, if I don't know if most of your offices are at the 300 building. And I'm in the 400 building at the School of Nursing, and this is the new building, the 426 North Ingalls building. So today, here are your learning objectives. So we're going to learn about the insights that will be valuable in addressing the inequities in the health that affect young Black men. We'll learn at least 2 ways for healthcare providers to apply their knowledge to positively impact those that are dealing with disparate care. We'll provide at least 2 learning points related to maintaining and sustaining and evaluating community-based partnerships and identify ways partnerships can influence practice in healthcare. So here's the data on adolescents and young adult health. Injuries, including road traffic, drowning, violence, self-harm, and maternal conditions are the leading causes of death among adolescents and young adults. And this data that I'm giving you, this is around the world. This is from the World Health Organization. So we see half of all mental health disorders in adulthood start by age 14, but most cases are detected and untreated. Many issues for adolescents and young adult health include unintentional injuries, which is number 1, interpersonal violence, which is number 4, mental health, including depression, alcohol and drug use, tobacco use, HIV/AIDS, other infectious diseases, and vaccination. We're also looking at HPV, which is also important. Early pregnancy, nutrition, obesity, physical activity, rights of the adolescent. And we have seen some of these issues with the population heightened during the COVID-19 pandemic. So what's the data on young Black males? So in the United States, I'll refer to them as YBM. Hold on one second. So in the United States, young Black males have a substantially greater need for sexual reproductive health services and are at a higher risk of contracting STIs than other young adult populations. The needs of this population are often under-addressed and insufficiently understood in a clinical setting. And there are significant gaps in access to care, which, as you see on here, will include STI screening, sexual reproductive health care, which is hard to reach within this population. But overall, young Black men carry a disproportionate STI burden with rates of syphilis, which is 4.7 times greater, gonorrhea, which is 6.5 times greater, and chlamydia 7.5 times higher than their white peers. Thus, the existing literature on the sexual reproductive health of young men, young adults, has focused on women's health or men who have sex with men due to increased exposure and healthcare costs. However, fewer programs have met the needs of young heterosexual Black males. And so that's what I look at is when I look at youth of color, but specifically young Black males with emphasis on heterosexual males. So what's the urgency to address this matter among young Black males? Well, this problem is particularly acute in urban areas like Detroit, which is in Wayne County. So if you're familiar with our counties, we're in Washtenaw. Wayne is the biggest county, one of the biggest counties in Michigan, which in 2019 had more cases of chlamydia and gonorrhea than any other county in Michigan, with nearly 15,000 new cases, more than 200 new HIV cases reported to the Detroit Public Health Department, and men ages 20 to 24 had the highest rates of gonorrhea and chlamydia. So here on the screen, it says there's a greater need, and studies show that there are significant factors in the decision to actually seek preventative services, which includes stigma, costs, health insurance, confidentiality, rapport with providers, clinic wait times, and STI and HIV testing. And as we move on, we need to understand what is the role of the healthcare provider in addressing health inequities. So you need to understand the major dimensions and resources of the community and the value of being trusted. So we talked a lot during this pandemic about trust and the vaccine and those type of things, but this just has gone, on for years in terms of how we can connect to not just this particular population, but all populations. As a nurse, I'm a little bit biased. I know that we're the most trusted healthcare provider, according to Gallup and some other polls. But in general, you need to understand the overall, what the underpinnings of what trust means. And so that means communication, rapport, being honest, respect for human dignity, transparency, and then contributing to the improvement of the community and betterment of the public health overall. And so you need to have the ability to understand how cultural and socioeconomic factors influence health and health behaviors on the patient, family, and the community. So because of my training as a clinician at all levels, I started off as a nurse in the ER at Henry Ford Hospital in downtown Detroit, moved on to school-based health, became a pediatric nurse practitioner, and then found things, and then I ran an adolescent health center for a very long time and found a lot of things that dealt with access to care, and then that I just wanted to keep pushing that envelope in terms of research. But I saw problems firsthand, and my values as a nurse, which include human dignity, integrity, autonomy, altruism, and social justice, all were packed in there. And so the patients and the families, the community first, these shined right through in both my research and my clinical practice. So the Young Men's Health Matters. So I talked about how I used to run a teen health center, and that was probably one of the most eye-opening jobs. It was one of my favorite jobs that I had, but there were not a lot of young men who would actually come to the center. We were in a school-linked clinic, which meant the services were not, you didn't have school-based clinics, which were attached to the policies of the schools. The school-linked centers had a lot more autonomy, and 80% of the services were sexual reproductive health. And so the times that I saw the young guys through were for sports physicals or for like job employment. And so that was one of the things that I found that I really wanted to dive into, was one of the populations that I had not really worked with, and at that center, we saw pregnant teens, we saw LGBTQ plus folks, we saw just the regular, like elementary kid, sports athletes. And so we saw a lot of diverse student populations, but I really didn't see the young men show up. So it was just something that, I really, had a passion for. In addition, my own father, men's health, he passed away of colon cancer when he was 59. I had my father-in-law, heart attack a couple of years ago. So I've been exposed to a lot of things where a lot of factors come in, not just the reproductive health, but men's health overall. So, and I enjoy it a lot. So, so when I worked with DCHC, I also, that's my, like I said, I mentioned my community partner. I told the CEO that when I finish my PhD, I'm coming back. And he was like, okay. I said, no, I said, I've identified several things. And I said, I'm going to do it the right way. I'm going to get some grants in here. I'm going to, I'm going to make a program. And I said, and this is going to help the center out. And it's going to help adolescents out. And so we have a really good relationship. We always had, and the executive leadership. But I don't know if he ever met anybody that said, I'm coming back, to do that specific work. But I did, and it wasn't just me, it was a team of people, the folks that work at Detroit Community Health Connection and the students that, or not students, but like medical residents, public health practitioners, nurses, like a lot of the service learning piece was huge there. So in addition to the Young Men's Health Matters program, I know the slide is just sitting here, I have several other programs that I do. I have the Stay Safe Project, which looks at clinic usage of young men throughout the city. I also have Project BMO, which is Black Males' Opinions on whatever topic that relates to healthcare. And I also have a masculinity project that we're doing. We had in-depth interviews to understand how masculinity impacts young men's health, specific to seeking out services as well. And so we're doing some qualitative coding right now. And this is all coming together in terms of the whole program. So I'm really happy to explain this to you. But anyways, the purpose was to establish a community academic partnership that would, one, build connections with a larger network. We wanted to improve the health and well-being of young Black males by identifying pressing health issues and defining future research questions. And we're looking at sustainability. And we wanted to use the principles of CBPR to improve community engagement and build trust and build tailored programs for young men, because we weren't the only, Detroit Community Health Connection is a federally qualified health center. And I'll go into that a little bit more. I'm not sure if you're familiar with that model. You may know names in terms of centers throughout the city and throughout the state of Michigan, but they're funded by HRSA. So we use CBPR to build this relationship. And we define CBPR as a partnership approach to research that is equitable. It involves all partners in all aspects of the research process. We look at the partners to contribute to their expertise, and we share the responsibility and ownership of what we're talking about. There's a phenomenon that we need to understand, and we integrate this knowledge to create interventions. And so as you can see, I'm not sure if you can see, but this was, this particular slide was from, or no, it's up in the front. Guzman in Israel. Mr. Guzman was the former CEO of the CHEAR clinic in downtown Detroit, and Barbara Israel, I'm sure you all know, is over at the School of Public Health and is the CBPR person. And so the first thing that we did was a needs assessment. That was phase one. And so I'm just going to redefine this. If you don't, I know public health folks, a lot of you folks may already know what a community needs assessment is, but I'm not sure if folks know how it benefits health centers. And so it's required by nonprofit organizations to have these community needs assessment, usually every 3 years. And it provides a snapshot of the current health issues and existing resources in a given space. We use it to enact policy change, system change, and environmental change. And it gathers culturally relevant responses that help direct the resources to where they're supposed to go, including our targeted population. And most of all, it builds trust within the community because we understand, what we have available. So here we published a paper on this particular needs assessment too. We had about 50, we had interviews about 50 staff and leadership to assist with resources, gaps, and more. And it was all done by nursing and public health students. And so that I published that along with the community partners and the students back in 2020 about how to do a community needs assessment in FQHCs. And so basically we redid their interview guide or their the actual needs assessment so that they can continue to use it every 3 years. We did a larger one, and then we did a focus one, which we did on adolescent health. And in that needs assessment, we found for adolescent health the top 3 pressing issues were mental health, obesity, and sexual reproductive health issues. And the 4th was LGBTQ access to care as well. So we did a short report on that. The next thing, we're building the community partnership. And so who are the key stakeholders? So we had a myriad of people express interest. We met both people on the east and west side of Detroit to accommodate location and needs of the members. The discussions were open. The facilitators were young Black males. I do have to mention that although I do work with young Black men, I'm not the face. I'm the researcher. So like, you know, when you're conducting things like focus groups, you need to have someone who connects with the community. And some of you may already know this, but we had to have someone who matched the population. So I have several young Black males on my research staff. And so they were 18 to 24. So they basically ran these community forums and talked to other Black men of all ages to talk about the pressing issues. And so we had 3 community discussions, 52 members expressed interest, approximately 50 members attended each session. And as you see here, we had a large amount of people from healthcare, mentoring. We had sports programs, and I'm not going to name like all the people who were involved, but we had some really nice organizations, including like big nonprofits and folks from there to come out and support. And so like, I was really surprised. And that particular initiative was done by the director of outreach at Detroit Community Health Connection, Mr. Derek Ware. And we just sent emails out, and it was like, it was word of mouth. So it was very powerful. So the Men's Health Forum data. So what we did was we wanted to see the most pressing issues. We used Poll Everywhere to ask anonymously about what they felt the issues were. And here's one, mental health. So the 5 issues here say socioeconomic factors, and these are kind of broad, but we wrote a paper on this too that we submitted, and we go more into this, but behavioral health and substance abuse, lack of education, and that was more so for sexual health and I think policing, violence, health issues. And on the right, it says, what do you believe are the most pressing issues, behavioral health issues in the community among young adult men? And so you see there on the right, we see drugs, trauma, rage, anger, there's, anxiety there. And so within the scope of this partnership and community advisory partnership, patient and community advisory boards are a new strategy. So different from governing boards to engage patients and the community with clinic leadership, these advisory boards are endorsed by such agencies as HRSA, which I mentioned before. And HRSA has a big grant called a 330 grant, which funds most federally qualified health centers. And that is where like the salaries come from, and some other areas that they fund as well. They're listed as a component of the patient-centered medical home certification. So DCHC is a patient-centered medical home model for all of their sites. I'm not sure who, like I should have asked what particular professions on here. I don't know if this is more physician driven, but patient-centered medical home models is a one-stop shop where, folks can get all of their care. So it's not just primary, like a physical, they can get their dental, they can get their mental health, they can get a registered dietitian. Is all in one space so that the patients don't have to travel from clinic to clinic. And it's a great model because, you have, pediatric services, and then you can get women's health care in the same space. So DCHC has both of those. And the rationale for the creation of this board is historic, as these boards allow the opportunity for shared governance and for health service to be tailored to the community's needs. Now, if you didn't know about also nonprofits, they have to have, and with FQHCs, they have a governing board. So the governing board has to, 51% of that board, they have to be patients of the health centers. So this is a little bit different. We were getting the actual patients in the community to make that board to have a different a different perspective in terms of what folks need. And so the impact of COVID came. So we had these great 3 discussions, and at the end we were supposed to do this really big conference in downtown Detroit. And so that was one of the goals. Like, we identified the issues, and then so we did the needs assessment, we had the discussions, and this is like also required. I don't know if people had questions about IRB and those type of things, but regardless of the IRB, this is something that the boards, community advisory boards, and then patient perspectives, this is something that's all required by their grant. So that's another thing with working with the organizations I mentioned before, like the needs assessment. When you're looking at these, working with them, there's boxes that need to be checked, and so that these things help both you and the partner out. So yes, the impact of COVID came, a double pandemic, which meant not only COVID-19, but it also meant the pandemic with civil unrest. And so during the height of SARS-CoV-2, the pandemic of the 2020 civil unrest, I used virtual spaces to reach hundreds of Black males online by engaging key leaders who represented their demographic across the state of Michigan, to engage them on a variety of health topics, as well as identifying the key priorities for the community. These topics included poor access to mental health services, the stigmas that prevent young Black males from receiving healthcare support, barriers to STEM education in the Black community, COVID-19 exposure. So we found out who was exposed. We're also publishing an article on that too as well. A lot came out of this project. And the risk behaviors that contribute to adverse physical and mental health outcomes for Black males. This experience provided a valuable opportunity to participate in community engagement and survey research that led to tangible findings for the health and wellness of urban communities and its population, including preliminary data on risk behaviors. And so we were forced to turn virtual. And so I will show you a few of the programs we had last year. And then this year we had 6 months worth of virtual programs that dealt with some of the things that it was split. And I'll tell you about that too. It was like young men. And then all of a sudden, when they got attention on young men, they wanted to do like all men. But that's another thing I'll mention at the end in terms of what we learned and lessons learned. So here we are with the program. That's Detroit. And the first program that we did was the Black Men's Health Summit. So this was supposed to be our conference. And we actually posted this right before George Floyd. And so we had like it all happened simultaneously, like a week before George Floyd, and then all of a sudden we had like 300 people register for this event. And so folks wanted an outlet to, they didn't know if they wanted to go places in terms of just to talk to someone about it. But here we had former police chief James Craig, who I believe is running for governor now. We had a pediatrician, we had a mental health provider, a counselor, a psychologist. We had Dr. Herbert Smitherman, who is the associate VP of the medical school at Wayne State. We had James Holly, who's a STEM and engineering professor at Wayne. And then we had Jason Wilson, who owns The Union, which is a place that teaches young Black males just about like like not only mental health spaces, but like how to just self-esteem and those type of things. It's a great organization right now, has a huge waiting list for young guys between the ages of I think 6 and 15. And so they each presented 20 minutes. And then we had the Lieutenant Governor, Garland Gilchrist, who brought in the introduction. So, and that day was actually the first protest, the peaceful protest in downtown Detroit. So people were trying to decide what they were going to do. So a lot of folks came out to this event and then and shared their thoughts, heard some of the speakers, and then they went down to downtown Detroit. So it was pretty cool. And then the next event that we had was Real Talk. Now this was more so my heart. And so we did a spinoff with young men. And so we had a dialogue on the health and wellness and success for young Black men. So this was really this is also, we had a huge turnout for this too, same month. And I'm not sure if you know, but June is Men's Health Month for all men. And so we had, again, Jason Branch, who was on, Dr. Jason Branch, who was on the Health Summit, was also on this because he was talking about mental health. We had Jay Reed, or Javier Reed, who is a hip hop artist, and he just released an album. He's from Michigan, but he lives in LA. We had someone from the city of Detroit. We had Dr. Anthony Adetamiwa, who is a physician, a pediatrician, and a public health advocate. He was also finishing his, I believe, his residency at one of the other FQHCs. And then we had Devin Gardner, who is a former U of M quarterback. I'm sure y'all know who Devin is. And then Javante Thompson, there's a big group called Teen Hype in downtown Detroit, and he lives in New York, and he's a business owner. He owns a couple restaurants, a vegan restaurant. So they're between the ages of 21 and 30. So we had a lot of young guys come on and ask questions and listen to them just talk. I mean, and this by far was my favorite. We had tons of questions and everybody stayed to the end. It was just such a great turnout. And so that was that in a nutshell. That was what happened in June. Instead of having our big conference, we had to just turn everything online in a matter of a month or so, and it worked out. Now this year we did 6 months worth of virtual events. And so as you see on the left-hand side, we looked at vaccine awareness. Obviously the COVID vaccine came out then. We had healthcare providers talk about what Detroiters need to know. And then February, we did an event with the American Heart Association. No, we didn't. We did an event with, who do we do an event with? No. That was in March. We did an event with the U of M Rogel Cancer Center. But yeah, we had Healthy Heart Awareness Month. Then in April, we did that was for the adolescents, for STI Awareness and Minority Health Month. We had a fitness panel bringing attention to, again, young men, those who are athletes, those who just want to get fit and eat better. And then in June, we had a 5K, a virtual 5K on the Detroit River front, and we used the River Walk, and we had about 100 participants. It was on Father's Day weekend, and we had about 100 participants participate, and they got a free pedometer, water bottle, like all this great stuff that we had. DMC sponsor. We had some folks from U of M, a podiatry place. But on the left, you see these are 3 guys who own their own companies in terms of fitness. And so we had a virtual conversation about getting healthy, because May is mental health month, but it's also, we wanted to do something different. So we did the physical fitness and wellness month. And so the next steps that we learned, and here, this is also a paper that we're writing up. It's the How to Build Trust and Rapport. And so in all, partnerships between communities and academic entities have been critical in addressing complex issues among communities of color and hard to reach population. The strategy of setting up a community advisory board for the health center in partnership with academic organizations was pivotal in the successful application of grant funds in this community. It also created a space to explore opinions and solutions that involve the community. We found that preparation is critical to carrying out these forums. This included a well-structured presentation, agenda, and prepared facilitators who represented the community. From the outset, we determined the established boundaries, checking on overall feelings of the group, including energy levels, interest in the subject, and whether the aims or purpose of the meeting was to be fulfilled. We were also persistent in sustaining communication and keeping everyone in the loop regarding goals, decisions, deliverables by open dialogue and emailing out post forums. So we have like a huge, I had like a huge, like, just a list from all of these events at like 500 or 600 folks, in terms of, most of them are men who received this information. And all of the information was sent to the executive leadership, the CEO, the chief medical officer, CFOs, COOs. They're all in the papers. So, and then we've actively presented to the boards. Other aspects noted, including maintaining Focus, given the variety of community needs, building trust between community partners and academic teams, recognizing barriers and facilitators, and looking at things like comfort level, meeting times and locations, and being flexible with the community advisory board members' needs. At the same time, this partnership had a fantastic response and attendance rate. And so what I must say is this, like I would say, I'm Dr. Jade Burns. And, one of the things people ask me, I am a professor at the University of Michigan, but that to them was like, the first question was, who do you know? How are you connected? Like, it's wonderful you're a professor, but who do you know? Who do you know? They really wanted to know how I was connected to the community. And I will say this, I am not from Detroit. I'm from Michigan. I'm from the suburbs, but all my family is from Detroit. They went to, they want to know what high school did you go to and those type of things. They wanted to know the connection. And so, my family went to, schools in the city. They lived in the city. And I, as a young person, I was always in the city just giving back. And so to me, it was just a part of me. And so, they wanted to know how long I worked in the clinic. And I've been with the FQHC for 10 years now. And so, it was really important to understand, how do you connect? And so I want to tell folks when they're working in those spaces, have a connection, and that it's a genuine connection. The other thing is that when we had these meetings, like I said, I would say, I'm this person, here's my connection. When I step back, and I learned this in my own dissertation, because I did some analysis on social media use with young Black guys. And it was just so therapeutic, the whole thing. I've never seen so many people just be honest and free and just talk about, what needs to be done. And then we had actionable items, and they were really into the process. And so it was just, especially when we're talking about mental health, which in the Black community isn't always, and many other communities, people don't really talk about it. I mean, we talk about it more now in the COVID-19 era, because we've been so affected. But people in general, there's a lot of trauma out there. And so, and it's not just, I learned more than just sexual reproductive health. I learned so much more as a clinician and as a researcher. And then the other thing was, I didn't really talk about this, but the Zoom piece, whether it increases access or not, I still think people really enjoy face-to-face, events. And so hopefully next year we can get to that point. It was convenient for a lot of folks, but there's still a digital divide in terms of how people access, and I'm sure folks know this maybe in the hospital, like with telehealth and those type of things. And then having a space where it's not, it's their own, it might be more convenient, but do they have the space where they can actually have privacy and those type of things? Did they even have headphones to listen to? Do they even have a smartphone that actually works and is compatible with Zoom and those type of things? And, but overall, we had good attendance. The one at, since it's in the city, I try to pull U of M, but a lot of stuff is through Wayne State. We had a lot of folks from the Wayne State Medical School and nursing schools who also wanted to learn about the community engagement piece as well. So it's about 9:50. So the conclusion here is the main goal of this presentation was to describe the development of a community academic partnership in urban FQHC that revolved around young Black men's health. The partnership was developed over several years through previous clinical and research relationships. And so those people who are part of the URC, you already know, or if you worked with community partners, that it just doesn't happen overnight. You have to be extremely patient, and you have to go with their schedule. And I know as academics and clinicians, we have our own schedule with patients and, writing and grants and those type of things. But we have to honor what these folks, the community, and I consider myself part of the community as well, what their time frame is. And so I did another talk about why it's important to have an academic person on board when you're doing research and those type of things. And that's another discussion. But you have to talk about the benefits, because people want to know, does this help our payment models? Does this help our reimbursement codes? I mean, does this help our grants, reports and those type of things? And so it can be an equal partnership. And then also, you can't just go in there with an idea. Like I had this idea, I knew it was already there, but for most folks, if you go in, it has to match. There has to be some middle point where you all can work together. It can't be only your vision, and they'll let you know if it's not going to work. And so even today, we still struggle on certain things. And, you know, little things like when you're giving stipends to community partners, like folks in the 9-to-5 world, or even in this world, they're used to getting checks like biweekly. And so when you say you're gonna give a stipend, you know, like you have to, you know, you talk to your grant folks, and then they push out a check, you know. So some folks are consistent with getting the monies over there. If you decide to give a stipend, if that's a part of your grants, those type of things, but all that has to be explained to them. So and you just have to be honest, and then it all has to be reported back. And then last, when we make these things like partnerships, we have to respect the clinicians. And I know those who are clinicians who are on the call, like, you know, you have charting to do, you have so much, there's so much that you have to do. And if someone comes in with some research and they don't fully understand, like not everybody's going to answer emails, like a lot of the stuff takes face to face in terms of the communication processes. And so I understood that part as working in the center, and I still work as a clinician contingently over the summer times. But those are just some tips that some folks don't think of, you know, and some folks are better at it than others. Some people, but the communication and the report is key. So I've just listed some resources here on the left side, you know, and this is available in terms of if you're interested in working with men and healthy people 20, there's actually no objective for men and healthy people 2030 or any of the healthy peoples. There's objectives for adolescent and sexual health, but not men. And so we need to do our due diligence. You know, I know I'm working with young men and young Black men because a lot of the research stems to middle-aged and older men, but we have to be able to help our young people make decisions and to help them understand how they can do better about their health, and that it's good to be in a setting and there are providers that look like you, or the providers that are empathetic or from the community that understand you as individuals. And you know, we want everyone to have good health, especially our teens and our young adults. So that is a critical time. So that's all I have. I want to say thank you. And if you have any questions, these are all website and everything. I think that's it. I know I talked a lot.
Thank you so much, Dr. Burns. We have a few minutes for questions, and this is usually an active group in engaging in the Q&A stage of the seminar. So if you would be willing, I'd like to open it up for any questions or discussion comments.
Yeah, most definitely. Are
Toby,
you,
please.
okay.
Oh, I can help moderate if that works for you.
Mm-hmm.
Yep.
Yeah, I see a hand raised for David. I saw your hand raised first.
Yeah.
I think I just called on Toby, and then we'll go to David and Lisa.
Okay, thank you.
Okay.
Thanks very much for your presentation.
David, sorry, I called on Toby very first. Maybe I said it quietly. I'm sorry. We'll circle to you in just a second.
Very good.
Sorry, I'm David, happy to have you go first, but so I'm the person that works with the Detroit URC and have a long history with CBPR, and I really appreciate all the insight that you brought. A question that young researchers, trainees, and faculty often ask me is how do you balance the academic pressures to publish and the pace and the need to be physically, you know, on campus doing clinical work with CBPR, when the whole emphasis of CBPR is relationship building and face-to-face and respecting the needs of the partners that you're working with. And I sort of have my lived experience, but I'm just very interested in hearing how you've navigated that and what advice you'd give to trainees on that score.
So, and I don't know if anybody else has published with community partners, but it takes a long time. And it's not because of the writing, it's because you got to get everyone to look at it and sign off and understand those type of things. And it might not be a priority. What I do when I work in those spaces is that I write as I'm doing everything, so that the writing part is easier. So like if we finish an event, if I have research assistants, I tell everybody just to write a summary, like write what you know. And then I'm writing, the process and the methods and those type of things. And I'm also a part of, I do a lot of stuff with IHPI, but they have a group with the community engaged folks. And so like getting feedback as you're doing it is really important. So if you have someone else who does community work or community-based work or in terms of the research, having them look at your stuff to make sure that like, what's the point? Because there's a lot of stuff that goes on in community work. And we don't always want to write about limitations. We want to write about the success, but and then you'll get a lot to write about. And so like last year when all of this happened, like I have so much to write about. And so I have all these papers started. So it's just now I'm just like, I just give myself like, you got to make a timeline according to your grants. You have to have people help you write, like even the research assistants, whatever they have to put on it, because all that's important because they see things that you don't see. And so when I do that, and then I put all the pieces together like a puzzle, and now it's just like a factory. We're just pushing out papers. And then with the grants, as soon as you have an outcome, like within FQHCs, they have, they have to have like outcomes, like they give generalized care, but they have to have like, and if anybody's interested, this is not my field, but diabetes, hypertension, and all that stuff. Like I found so much other stuff that is not, you want to collaborate with other folks too, so that your names can go in those papers or those grants and those type of things. So there's a lot of other things that you can pull in together. So I hope that answers the question.
David?
Yeah, thank you very much. It was a very interesting presentation and clearly hard work. I'm wondering in general about how one perhaps targets change in behavior like health outcomes or behaviors related to health outcomes that is perhaps indirect. So when I was doing my fellowship in New York City, this was in the 80s, there was a very creative program for prevention of teenage pregnancy. Mm-hmm. And the focus of that program was on jobs for youth. Mm-hmm. And the notion was that if one introduced youth, both boys and girls, to jobs where they were being mentored. So these weren't just like working in fast food, but jobs where they were being mentored, that they would see their future in different ways. And they would sort of see what they might be sacrificing if they became pregnant or if they became a father. And I'm just wondering, in health promotion programs, are there many that sort of target those things, like violence in the community, change? Like if your efforts are directed towards sort of getting to the ills in general within a community, health will follow.
I'm going to just say, because I know we're at time, if people need to drop off, you can always follow up directly, I'm sure, with Dr. Burns or through us at CHEAR. But I'm going to keep it open for another 5 or 10 minutes so that we can finish this conversation for those that can stay and want to. If that's okay with you, Dr. Burns. I understand if you have to go.
Yeah. And I think I understand your question. And I can only give the example like this. Like I understand you're saying like job training, and then they look at other aspects, how that can reduce or make health better. So I look at sexual reproductive health, right? And so you can't just look at sexual reproductive health without looking at how it impacts mental health, how it looks at like things like eating and those other type of behaviors. And so in my own research, I sometimes I want to ignore those factors, but I can't. And so then I end up collaborating with folks to help understand like, okay, well, if you're having sexual relations with somebody, maybe you're depressed, you know what I mean? And if you feel good about yourself, if you have a job, if you have a supportive partner, if you have things in your life that are, you know, maybe the decisions that you make will be better. The other thing is, for me, I rely on the theory. So I look at one outcome, but if I use the theory of planned behavior for most of my work. So if I'm looking at like condom use or some of those other things, I'm also looking at some of the things like the antecedents, like things like environment, or like I use a socio-ecological model where it's not just, okay, I'm looking at, again, condom use or whatever, or social media. I'm looking at how does the actual community, like your neighborhood, your environment. So if you're in a place, like how do your next door neighbors impact your behaviors and decision making? And if you have like a second person who's like a father or the grandmother next door or those type of people in your life, then you have more support, then it automatically leads to better decision making. And I'm just making this up. And so I look at those external factors. So does that make sense? Did I answer your question? So health promotion. So if you have these programs in the community, you also have to look at the resources that are around the community, the providers that provide the care, because a lot of times you have providers just leave. You know, you get these these types of grants where they'll pay you to work in underserved areas, rural or whatnot, and they get frustrated. In part, it's not because they're not providers, because they don't understand what's around them. So they need like extra residency programs to understand that people aren't showing up to, their appointments because they can't get on the bus, or the bus line there's no service line. There's all these other things that, are external factors. And so to answer your questions, one, I like, yes, I always look at more than just that one outcome. And two, I rely on the theory to help me, impact those external factors that, like you're saying, like job employment and those type of things. And as a result, we can create additional programs because of those things. And last, I look at things like the providers and other things that have a huge influence, but they themselves also need to be trained, and so that they can not quit on our patients. And like, if you have a trust, like providers have so much power that they can also have external or alternate outcomes for the patients that they serve as well. Does that make sense? Okay.
Lisa?
Thank you. Well, first of all, thank you so much for an excellent seminar. It was really terrific to learn about all the work that you're doing, and more about community-based participatory research. I have more of a comment than a question, and invite your thoughts about this. But in our field of child population health research, we have been talking for many years now for patient-centered outcomes research, and really working to engage the patient population. But for those of us that are working in the area of prevention, the community is really our patient population. And I think it's really incumbent on all of us to start thinking more broadly. That we'll often run focus groups, for since child health for parents and adolescents often. But I think it's really important for us to start thinking more broadly and being more engaged with the community as we think about trying to be more effective with our prevention outreach. And just wanted to get your thoughts about that, kind of like any suggestions on initial ways to start thinking about expanding our work in those areas.
I think you hit everything on the mark. I just when we're providing care, and this might be just because it's from a nursing framework. For me, it's not just about the patient, it's about everything else that's around them. So you might have this great, I remember working in the ER, and you might have this great heart medication that can help whatever X population in the hospital, right? And so that your outcomes are going to be fantastic. They're going to be statistically significant. But then once they leave those ER doors, then what happens? So we need to understand what's going on before we even provide that medication, to make sure that they will continuously take the medication. Or I'm just giving that as an example, but we just have to ask, and and it's interdisciplinary. Like I can't just ask, I'm a nurse practitioner, but I need help of the dietitian. I need help of the social worker to make these things happen. And so you can't do this alone. you have these great ideas. You can't do this alone. You see more as a practitioner than other people. But if you want things to happen and take action, I have to have everybody on board. I even have to have my insurance companies on board. You know what I mean? Like they're not going to reimburse you. You know what I mean? Like you have to think about like we have people come in and do all this work, and then I'm like, so what's the billing code for it? Like, how do we continue this conversation? You know what I mean? Like, you know, you identify these great things. So how can our providers put this in the EMR? How can our providers bill for this? How can our, like, the difference between a physician, a nurse practitioner, and a physician's assistant, or our other services, you know, like it's not always on a billing, but I'm just, you know what I'm saying? Like we do a lot of work in these service industries, and then some of it doesn't even get recognized. And so that we have to think about our patients. We have to think about the centers that we, you know, to make sure that they are up and running, that they can still run, and all those things count, all those things matter. So yeah.
Well, thank you again, Dr. Burns, for affording us a few more minutes of your time this morning. This was an excellent seminar.
Wait, I'm still on record. I don't want to go back.
We still aren't recording.
Well, thank you so much. And like I said, I, you know, like our brand is We Dare. So I dare you to think, like, how can you, like Lisa said, like incorporate, you know, we talk about prevention, like what can you do? Like you might be in the ICUs, I don't know, dealing with, like, what does that mean when your patient moves down, step down? Or what does that mean? Like, I just dare you to think about how you can think about your patient as they move through these health systems, whether it is inpatient, outpatient, you know, on the side, in the streets, or whatever the case is. We have so much power as researchers, clinicians, practitioners. How can we use it beyond just this little space here that we're thinking about? So
that's great.
It's a great message to leave us with, and I'm sure there may be people that follow up with you to continue to discuss this. But again, thank you for joining us this morning, and good to see everyone. We'll be back here in another 2 weeks.
hey, thank you. Stay safe.
Thank you so much. Bye-bye.